Welcome back to the Deep Dive, the show built to take complex clinical information, filter out the noise, and really deliver what you need to be an expert practitioner.
Great to be here.
Today, we are opening up what I consider one of the most technologically fascinating and, frankly, emotionally crucial areas of practice: prenatal diagnostic tests. This is the heart of Chapter 15 in maternal-child nursing, and it's just non-negotiable knowledge for anyone caring for pregnant women.
It truly is. Our goal for this deep dive is to give you a complete step-by-step masterclass on these procedures. It's not just about memorizing names.
Right.
It's about understanding the physiological principles behind why we order a specific test, what the results mean, and crucially, how you as the nurse protect the mother and the fetus throughout that entire process.
Okay, let's unpack this with a clear mission statement.
Yeah.
The clinical objectives of these procedures, they really fall into three buckets, right?
Yeah, that's a good way to put it.
First, we need to detect congenital anomalies.
Yeah.
Is there a problem with the baby's structure or, their genetics?
That's number one.
Second, we need to evaluate the condition of the fetus in high-risk pregnancies to know exactly when we might need to intervene, maybe with an early delivery.
And that's the surveillance piece. The third objective, and this is the one that's often overlooked, is simply getting reliable baseline information.
Like an accurate gestational age.
Exactly. An accurate gestational age, which is the anchor for literally all subsequent care decisions. That third point accurate dating is the foundation of everything.
How so?
Well, without a precise understanding of gestational age, we can misinterpret biochemical screening results, we can miscalculate due dates, and we can even make critical errors about fetal maturity before an intervention.
I see. So it all builds on that.
It really does. When you understand these diagnostic tools, you move from being a general caretaker to a specialized guide. You're anticipating risks and ensuring we intervene precisely when fetal compromise starts to outweigh the risks of delivering early.
And before we get into all the technology, we have to talk about the emotional side of this. The stakes are so high.
Absolutely.
On one hand, technology gives us that beautiful, reassuring window. Seeing the heartbeat, knowing the sex, watching the baby move.
It can be a wonderful bonding experience.
But it also drastically raises the emotional temperature. Abnormal results increase anxiety exponentially. And these tests, they often force parents into difficult, life-altering ethical decisions about what to do next.
You're dealing with families at their most vulnerable. Precisely. And in your practice, you won't always be ordering these tests, but you absolutely must recognize the indications that necessitate them.
Which brings us to high-risk pregnancies.
Right. We use these diagnostic procedures most frequently in pregnancies that we define as high risk. That list of indications is comprehensive, and you, as the nurse, are often the first to recognize these factors.
Okay, let's dedicate some time to this. Let's run through these risk categories, because knowing them really informs your initial assessment and your triaging. We can start with the pre-existing or current medical conditions the mother might have.
Sure. This includes chronic issues that affect vascular health and oxygenation. So things like pre-existing or gestational diabetes, chronic hypertension, or the development of preeclampsia.
Things that affect blood flow.
Exactly. We also look at severe anemia and current or acute infections like pyelonephritis or STDs, which can significantly impact the fetal environment and oxygen supply.
And what about genetics?
That's a massive indication. When the parents are known carriers or they express a genetic disorder, think cystic fibrosis, sickle cell anemia, Tay-Sachs, in those cases, testing is proactive, not reactive.
Okay, next category. Let's pivot to demographic factors.
Right.
These are broad, but they correlate really strongly with higher risk profiles.
They do. Maternal age is the classic one, under 16 or more commonly over 35 years old.
Why over 35?
The risk for chromosomal anomalies just goes up significantly with advanced maternal age. We also see higher risks linked to socioeconomic factors like poverty. And statistical data shows that non-white ethnicity has a higher statistical risk for prematurity and infant death, which is often tied back to socioeconomic and access to care issues.
And that access to care piece is huge, isn't it?
It's a huge red flag in the demographic context. Inadequate prenatal care. If that initial visit happens after 20 weeks, or if the mother has fewer than 5 total prenatal visits, we have missed critical windows for dating, for screening, for intervention. That absence of baseline data puts the fetus at risk.
Right, you're flying blind.
Pretty much.
Then you have the obstetric factors, the history the mother brings to the table from previous pregnancies.
Exactly. So if she has a history of preterm birth, which is less than 37 completed weeks, or a low birth weight infant that's under 2,500 grams, that history elevates the risk for the current pregnancy.
And multiples.
Multifetal pregnancies, like twins or triplets, always necessitate increased surveillance. Always.
What else falls under obstetric factors?
Other critical ones include malpresentation, so a breech or shoulder presentation near term, a previous fetal loss, or having delivered a prior infant with a congenital anomaly. We also keenly track amniotic fluid volume.
Ah, okay. Amniotic fluid, that's a key marker of chronic fetal health, right?
It really is.
Let's detail the fluid abnormalities because I know those necessitate immediate follow-up. First up, hydramnios.
Right, hydramnios or polyhydramnios just means excessive amniotic fluid. This is defined as greater than 2,000 millil at term, or if we use the amniotic fluid index, the AFI, it's a measurement greater than 24 or 25 centimeters.
Say the opposite.
The opposite is oligohydramnios, insufficient fluid. So less than 500 millil at term, or an AFI that's less than 5. Both conditions put the fetus at risk and require rigorous, ongoing surveillance.
Okay. Are there any other obstetric risks to round out the list?
We'd round it out with grand multiparity. That's 5 or more previous pregnancies, and signs of current fetal distress, like the mother reporting decreased fetal movements, or if there's uncertainty about the gestational age, or we suspect intrauterine growth restriction, IUGR.
Got it. Finally, we have to consider concurrent maternal factors, things related to lifestyle and physical state.
This includes extreme pre-pregnancy BMI, whether it's underweight, so less than 18.5, or overweight and obese, which is 25 or higher.
And weight gain during pregnancy.
Yes. Inadequate or excessive weight gain during the current pregnancy is also a flag. And naturally, any substance use.
And that's a broad category.
It is. It encompasses legal drugs, over-the-counter, herbal supplements, illicit drugs, alcohol, and tobacco. Any of that requires heightened monitoring. Recognizing this entire mosaic of risk factors is really the critical starting point for your nursing assessment that triggers the use of these diagnostic tools.
Perfect. With that context established, let's move on to the first and most foundational diagnostic tool in our arsenal, this ultrasound. Ultrasound is truly amazing technology. How does it actually work?
It operates on a pretty simple principle: high-frequency sound waves. These waves are transmitted into the abdomen, and when they hit objects, tissues, bone, fluid, the different densities cause them to deflect and return as echoes.
And the machine reads those echoes.
Right. The machine converts the timing and the intensity of those echoes into 2-dimensional, 3-dimensional, or even 4-dimensional real-time images.
And that real-time aspect is what makes it so powerful.
It is. It allows us to observe fetal movement, breathing activity, the actual beating of the fetal heart. While we capture still images for clinical measurements, it's that dynamic live visualization that confirms viability and lets us track immediate fetal well-being.
And this is where the human element comes in so strongly. For many expectant parents, the ultrasound is the first concrete visual evidence of their baby.
It is. They often report an overwhelming rush of love and protectiveness, but that vulnerability, it's a double-edged sword. Well, they can also experience intense anxiety because they know the technician is looking for something. And that something could be an anomaly. As a nurse, you need to recognize that tension in the room.
Absolutely. The technician might point out the fetus waving, which is a fun moment of connection, and of course the expectation of finding out the sex is often sky high.
It is. But you also need to counsel patients that sometimes the baby's positioning prevents a definitive gender ID, which can lead to a surprise later on.
Now let's distinguish between the two primary types based on timing, starting with the first trimester ultrasound. This is typically done transvaginally, right?
Yes, the transvaginal route. And the reason for that early on is purely anatomical. In the first few weeks, the uterus is still deep within the bony pelvis.
So a regular ultrasound can't see it clearly.
Exactly. The transabdominal route, passing through layers of fat and muscle, just can't get close enough to achieve clear resolution.
So what's the procedure like for the patient?
The woman is in the lithotomy position, and a specialized probe, which is protected by a cover and coated in gel, is inserted into the vagina.
And the purposes of this early scan are very specific.
They're foundational. First, to confirm the presence and the precise location of the pregnancy. Is it intrauterine, where it should be, or is it a potentially life-threatening ectopic pregnancy?
It also detects multiples.
Right, multifetal gestation. And it's the gold standard for estimating gestational age in this window. The key measurement here is the crown rump length, or CRL.
Why is that so accurate early on?
Because in the first trimester, before a lot of genetic variability in size kicks in, the CRL is cited as the most reliable indicator for dating. It's often more accurate than the mother's last menstrual period.
Yeah, you can see a heartbeat.
Yes, confirmation fetal viability is key. We can generally see the fetal heartbeat once the embryo measures at least 5 millimeters in length.
What else are you looking for?
We're also identifying any maternal abnormalities that could complicate the pregnancy, things like uterine fibroids, ovarian cysts, or a bicornuate uterus. And finally, it serves as an essential visual guide when performing other procedures, like chorionic villus sampling.
Okay, so as the pregnancy progresses, the uterus grows up and out of the pelvis.
Right, it elevates into the abdomen, and at this point, usually around the beginning of the second trimester, we transition to the second and third trimester ultrasound, which uses the transabdominal technique.
Proper maternal positioning during this longer procedure is a major nursing responsibility.
It is. The mother is placed supine, but her head and knees are supported, and crucially, she must be turned slightly to one side, a lateral tilt.
We often place a wedge under her hip for that.
Exactly. And that simple maneuver prevents supine hypotension syndrome.
Explain that for us.
That's where the heavy, gravid uterus compresses the vena cava and the aorta. This reduces venous return to the heart, causing a drop in maternal blood pressure and, consequently, reduced placental perfusion. It's a simple fix for a serious problem.
What about bladder prep for this one?
Good question. Sometimes in the second trimester, a full bladder is requested, similar to pelvic exams. It helps elevate the uterus and displace the intestines, improving visibility.
And in the third trimester?
By the third trimester, the uterus is large enough that a full bladder is often unnecessary, and it might just cause the mother discomfort.
So the goals in these later trimesters are much more expansive than just dating.
Oh, much more. We're still confirming viability, of course, but we're also estimating gestational age using multiple measurements now.
Like what?
Things like the biparietal diameter, BPD, the femur length, FL, and the abdominal circumference, AC.
And a key insight here is that you're looking for a trend.
Precisely. While a single measurement gives an estimate, sequential assessments of multiple parameters over time are far more accurate for detecting growth issues and confirming the dating.
And beyond dating.
We are thoroughly evaluating the fetal anatomy, comparing growth parameters in twins or triplets, and performing a comprehensive assessment of the amniotic fluid volume and the precise location of the placenta and umbilical cord.
Why is the placental location so critical?
Knowing the location is critical, especially if the placenta is low-lying or covering the cervix, which is a condition called placenta previa. It has major implications for delivery. And of course, the transabdominal ultrasound is the necessary visual guide for procedures like amniocentesis.
Let's discuss the comprehensive examination. This isn't the standard scan, right? This is done specifically when there are high-risk factors.
Exactly. Or if screening tests like the MSAFP come back abnormal, or if we find clinical issues like hydramnios or oligohydramnios, this exam is extremely detailed and specifically hunts for anatomical defects.
And the level of detail you can see is remarkable.
It really is. We can detect the majority of open neural tube defects, like anencephaly, where the cranial vault is absent, or myelomeningocele, which is a severe form of spina bifida.
What about other parts of the body?
We look for abdominal wall defects, such as gastroschisis and omphalocele. We can see malformed kidneys, hydrocephalus, facial defects like cleft lip or palate, and various limb abnormalities.
A quick clinical note here. Maternal obesity can be a real challenge.
It can. It can significantly limit the accuracy and the clarity of the ultrasound image, which is a constant challenge in practice.
So, to summarize ultrasound, the massive advantage is its safety. It's non-invasive, comfortable, gives immediate results.
And it's often very reassuring for the parents. But the limitations are equally important for you as the nurse to understand. It cannot detect all defects.
Right, especially non-structural ones.
Exactly. Things like inborn errors of metabolism. Also, if a woman gets late prenatal care, we miss that optimal window for early dating. And perhaps most frustratingly, inconclusive results can often generate more anxiety and require expensive, stressful follow-up testing.
Okay, now let's move to the specialized ultrasound applications that focus specifically on circulation and blood flow. Let's start with Doppler ultrasound blood flow assessment.
This takes the echoes and analyzes movement, transforming sound into critical diagnostic data about blood flow.
And the underlying principle is the Doppler shift.
Right. As blood flows through a vessel, the frequency of the returning echoes changes based on the speed and direction of the flow during the heart's cycle systole and diastole.
And when is this assessment primarily used?
Overwhelmingly, it's used in pregnancies complicated by hypertension, preeclampsia, or fetal growth restriction, because all of these conditions are often symptoms of placental insufficiency.
So you're looking at how well the placenta is working.
That's the core of it. The crucial clinical measurement we look for is the systolic-diastolic SD ratio, which we most often measure in the umbilical artery.
Okay, explain that ratio. What's normal?
Normally, as the fetus and the placenta grow and mature, the resistance in the placental vessels decreases. This allows more blood to flow freely, especially during diastole, the resting phase of the heart.
So the SD ratio should go down over time.
It naturally decreases as gestation progresses, yes.
So what does it mean when it goes up?
Here is where the pathology becomes clear. If the placenta is insufficient, meaning it's aged prematurely or it's damaged by hypertension, the fetal peripheral resistance in that placental vascular bed increases significantly.
It's harder for blood to get through.
Exactly. This increased resistance chokes off the blood flow during the heart's resting phase, causing that diastolic flow to fall dramatically. When the diastolic flow drops, the SD ratio goes up, which is a direct indicator of mounting fetal compromise and hypoxemia.
And this is where the brain-sparing effect comes in, right?
You got it. That's the really critical insight. This is the compensatory mechanism. In moderate cases of placental insufficiency, the fetus reroutes blood flow, prioritizing essential organs.
So when you see that rising resistance in the umbilical artery, you're also looking at the brain.
Precisely. We often pair that assessment with a look at the middle cerebral artery, or MCA. Normally, the MCA is a high-resistance vessel, but under chronic hypoxia, the fetal brain vasodilates to increase blood flow. That's the sparing effect.
So you'd see low resistance in the MCA.
Yes. If we see that high umbilical artery resistance and low MCA resistance, it tells us the fetus is already compensating for chronic oxygen deprivation. That often warrants immediate intervention.
And in the most severe cases?
In the most severe cases of growth restriction due to profound placental failure, the diastolic flow in the umbilical artery can be completely absent or even reversed, where blood flows backward.
And that's an emergency.
That finding is an extremely ominous sign demanding immediate action.
Okay. So then we have color Doppler imaging. How is that different?
Color Doppler basically overlays this circulatory data onto the structural imaging, making these complex vascular systems much clearer to see.
It uses color in a couple ways, doesn't it?
It does. Non-directional color Doppler uses a single color just to identify stationary structures, like counting the 3 vessels in the umbilical cord. Directional color Doppler is the dynamic part.
That's the red and blue we always see.
Right. It uses 2 or more colors, typically standardized as red for flow toward the transducer and blue for flow away, to determine the direction and speed of blood flow and pulsations in real time.
What's the clinical application for that?
It's invaluable for evaluating the structural normalcy of the fetal heart, specifically the relationship between the major vessels and the heart chambers. It can help diagnose certain congenital heart defects. It also assesses blood flow and pulsations within the umbilical cord and, critically, in those cranial vessels, which ties right back to that brain-sparing mechanism we just discussed.
Perfect. Let's shift now from visualization and circulation to biochemistry, starting with alpha-fetoprotein screening, or AFP.
This is a non-invasive screening tool that provides a risk assessment based on what we find in the mother's blood.
So what is AFP? Where does it come from?
AFP is the dominant protein found in fetal plasma. It's produced primarily by the fetal liver and the yolk sac. It moves from the fetus into the amniotic fluid, which we call AF-AFP, and then it crosses the placenta into the maternal circulation, which is what we measure as MS-AFP.
And the concentration changes over time.
It does. It naturally rises with gestational age, and it's higher in multifetal gestations simply because there's more fetal tissue producing the protein.
And there's a key nursing responsibility here: precision and context.
Absolutely. The test is ideally offered between 16 and 18 weeks of gestation, and the measured values must be meticulously corrected for maternal weight.
Why the weight correction?
If the mother has a larger plasma volume, the AFP produced by the fetus is diluted across that bigger volume. This could potentially give you a falsely low reading, which could mistakenly raise the risk flag for something like Down syndrome.
And I want to really hammer this point home. This is the essential educational point the nurse must convey.
Yes. AFP is a screening test, not diagnostic.
So, yeah.
It is a screening test. It is not diagnostic. An abnormal result is a statistical flag. It only indicates the need for further, often invasive investigation. It does not provide a definitive diagnosis.
So let's look at the two categories of abnormality. What do elevated levels mean?
Elevated levels are most often associated with a failure of the embryonic neural tube or the anterior body wall to close properly.
So things like spina bifida.
Exactly. Open neural tube defects like anencephaly and spina bifida, and abdominal wall defects like omphalocele and gastroschisis. Elevated AFP occurs because that open defect allows the protein to leak directly into the amniotic fluid and then into the maternal blood.
But there are other, more benign reasons for a high AFP.
Yes, and this is where the false positives come in. This includes conditions like a threatened abortion, fetal demise, a multifetal gestation, or the most common benign reason, underestimation of fetal age.
So if the pregnancy's further along than you thought, the AFP is expected to be higher anyway.
Precisely. So the result looks falsely high when it's dated incorrectly.
Okay, what about low levels of AFP?
Low levels are associated with chromosomal trisomies, most significantly Down syndrome, trisomy 21, and also gestational trochoblastic disease.
And again, dating can be an issue here.
Right.
The benign factor of overestimation of gestational age can also cause a falsely low reading, which leads to a lot of unnecessary anxiety.
The advantages of AFP screening are pretty obvious. It's simple, economical.
And it's the least invasive way we have to screen for these major defects. It gives parents time to consider their diagnostic options or prepare for the birth of a child who might have special needs.
But the limitations are what dictate how we counsel patients.
They are. As we discussed, benign conditions like inaccurate dating frequently cause abnormal results, which generate significant parental anxiety and the expense of follow-up tests.
And it can't detect everything.
No. Another limitation is that if a structural defect is closed, meaning it's covered by skin, it won't cause AFP leakage. So a normal AFP level does not guarantee the fetus is free from all structural anomalies. Plus, that optimal timing of 16-18 weeks is often missed if a mother initiates prenatal care late.
So to increase the accuracy, especially for chromosomal anomalies, we use multiple marker screening. Yes, this takes the foundation of the MSAFP and adds other maternal serum markers to create a more complete risk profile.
The traditional triple screen adds what?
It adds human chorionic gonadotropin, HCG, and unconjugated estriol to the MSAFP. The characteristic pattern for a positive screen, so an increased risk for Down syndrome, is low MSAFP and low estriol, combined with a high level of HCG.
And now there's a quad screen.
Right. To improve the sensitivity and specificity even further, many centers now use a quad screen, which includes a fourth marker, inhibin A, a placental hormone.
And that helps with accuracy.
Yes. This addition significantly improves the accuracy for detecting trisomy 21, particularly in women under 35 who aren't automatically flagged by advanced maternal age.
And if any of these screening profiles come back positive,
the next step is nearly always additional definitive testing, so an advanced level 2 ultrasound or an amniocentesis for definitive karyotyping.
Okay, that's a perfect transition. Let's move into the domain of those invasive procedures, which carry inherent risk but give you definitive diagnostic answers. We'll begin with chorionic villus sampling, or CVS.
Right, so CVS is a procedure designed to sample the chorionic villi. These are rapidly dividing fetal cells that share the exact chromosomal and genetic makeup of the fetus.
And the key advantage of CVS is timing.
It's all about timing. It's performed exceptionally early, typically between 10 and 13 weeks of gestation.
So what's its primary indication?
The diagnosis of chromosomal, metabolic, or specific DNA abnormalities when there is a known parental risk. It's important to note, though, because it only samples tissue, CVS cannot diagnose defects that require measurement of amniotic fluid markers.
Like open neural tube defects.
Exactly. Can't do it.
And pre-procedure counseling is essential.
Absolutely. Informed consent must cover the specific non-negligible risks. The sample can be obtained using two approaches. Transcervical, where a flexible catheter is inserted through the cervix, or transabdominal, where a needle is guided through the abdominal wall, much like an amnio.
What's the post-procedure nursing care look like?
It's immediate. We assess maternal vital signs, we check the fetal heart motion via Doppler or ultrasound, and we instruct the woman to report any heavy bleeding, the passage of clots, or any tissue. Usually, several hours of rest is required.
So the massive clinical advantage, again, is the timing, first trimester results.
It allows for much earlier decision-making if the results are abnormal. This gives the family and the providers more options than procedures that are performed later in the pregnancy.
But the limitations, they dictate caution. There are real risks.
There are. The pregnancy loss rate is around 2.5%, which is slightly higher than a mid-trimester amniocentesis. And there's a specific procedure-related risk, an increased incidence of limb reduction defects if CVS is performed too early.
And too early is before 10 weeks.
Correct. Before 10 weeks of gestation. Furthermore, there's a risk of uterine infection. If that transcervical approach is chosen, it is strictly contraindicated if the woman has a known cervical or vaginal infection.
Why is that?
Because you could literally seed the uterine cavity with bacteria, and a critical nursing action. RhoJam must be administered to all unsensitized Rh-negative women following the procedure.
Because of the risk of fetal-maternal hemorrhage.
Right, which can cause Rh sensitization. There's also a practical limitation. The sample is very labor-intensive in the lab. Technicians have to meticulously separate and remove maternal cells from the fetal villi sample before they can culture it, which adds to the cost and complexity.
Okay, let's pivot to amniocentesis. This is the aspiration of amniotic fluid directly from the amniotic sac.
And timing is crucial here, too. For identifying genetic abnormalities, the ideal window is the mid-trimester, between 15 and 20 weeks.
Why that window?
That's when the fluid volume is adequate for a safe tap, and the ratio of fetal cells to fluid is optimal for culture.
You can technically do it earlier?
You can. Early amnio is possible between 11 to 14 weeks, but we generally avoid it unless we absolutely have to. Studies show it carries a higher rate of fetal loss and an increased risk of fetal foot deformations if it's done before 13 weeks.
Likely from the fluid removal.
Yes, likely due to the earlier removal of fluid impacting fetal movement and positioning.
The purposes of amniocentesis are really separated by trimester, aren't they?
They are, distinctly. In the second trimester, as you mentioned, we're looking for chromosomal and biochemical abnormalities, diagnosing amnionitis if we suspect infection, evaluating the fetal condition in cases of Rh sensitization, and testing AF-AFP to explain a weirdly abnormal MSAFP result.
But in the third trimester, the goal shifts entirely to immediate management.
Completely. We are determining fetal lung maturity or evaluating fetal hemolytic disease due to Rh incompatibility. We might also perform a reduction amniocentesis to drain excess fluid in a severe case of hydramnios.
Let's focus on fetal lung maturity. This is a life-saving determination before any non-emergency delivery at or before 38 weeks. We need to know if the fetus has enough surfactant.
Right, to prevent respiratory distress syndrome, or RDS. The classic test is the lecithins-sphingomyelin ratio, the LS ratio.
Explain that.
Both are lipoproteins that make up surfactant. They're present in roughly equal amounts until about 30 weeks. After that, lecithin production surges. An LS ratio greater than 2.1 generally indicates mature lungs.
But there's a huge but here, a key clinical distinction that a good nurse needs to know.
Yes, an LS ratio of 2.1 may not ensure lung maturity in fetuses of diabetic mothers.
Why not?
High circulating insulin in the fetus, which is due to the maternal hyperglycemia, is known to inhibit the synthesis of another key component called phosphatidylglycerol, or PG.
So in diabetic pregnancies, you need more information.
Yes. We rely on additional phospholipid tests, specifically phosphatidylglycerol, PG, and phosphatidylinositol, PI. The presence of PG is a much stronger confirmation of lung stability and maturity than the LS ratio alone in this specific high-risk population.
Okay. What about testing for fetal hemolytic disease?
In Rh-sensitized women, the amnio is done to determine the fetal bilirubin concentration in the fluid. This level is a proxy for the amount of fetal red blood cell destruction that's being caused by the maternal anti-Rh antibodies.
And that lets you assess the risk for severe anemia.
For severe anemia, erythroblastosis fetalis, and the potentially fatal condition, hydrops fetalis.
Procedurally, the nursing role is vital.
Absolutely. The woman is positioned supine with that essential lateral tilt. We establish baseline FHR and maternal BP. Ultrasound is used continuously to guide the needle into a fluid pocket away from the fetus, the placenta, and the cord.
And what of the fluid itself?
The physician discards the first 1 to 2 milliliters to prevent contamination by maternal cells, and then typically removes about 20 milliliters for analysis.
And post-procedure monitoring is non-negotiable.
Non-negotiable. Electronic fetal monitoring for 30 to 60 minutes to ensure fetal well-being. The mother must avoid strenuous activity for 24 hours. And you have to instruct her to report contractions, vaginal bleeding, fluid leakage, or fever.
And RhoJam again.
And just as with CVS, RhoJam is mandatory for all unsensitized Rh-negative women.
The major drawback of mid-trimester amnio for genetic diagnosis really remains the timing.
It does. Results often take 2 or more weeks. That means the patient is frequently 18 to 22 weeks pregnant. They've often felt the baby move, and the emotional and ethical difficulty of making a decision based on abnormal results is just immensely increased compared to a first trimester diagnosis.
Our final invasive procedure is the highest risk. Percutaneous umbilical blood sampling, PUBS, also known as chordocentesis.
Right. This involves the aspiration of fetal blood directly from the umbilical cord, usually near the placental insertion point because it's more stable there.
And PBS is generally reserved for severe immediate issues.
It is. The major indications are intruders in management of severe Rh disease, specific fetal infections, or disorders that require immediate access to fetal blood for rapid testing. While you can use it for karyotyping, other lower-risk methods are usually preferred now.
There's a key procedural detail for the nurse here about which vessel is used.
Yes. The umbilical vein is the preferred puncture site because it's larger and less prone to spasm or constriction than the artery. However, when you're assessing immediate fetal acid-base status, the distinction matters.
How so?
Blood from the umbilical vein is oxygenated and leaving the placenta, so it has lower CO2. Blood from the artery is returning from the fetus, so it has higher CO2. Knowing which vessel was sampled is critical for interpreting the blood gas results accurately.
And the risks with PBS are significant.
They are. It requires highly specialized centers. The risks include fetal loss, infection, severe fetal bradycardia, cord laceration, hematoma at the puncture site, and inducing preterm labor or premature rupture of membranes. And of course, ROJAM is required for our unsensitized Rh-negative women.
Okay, let's move from definitive diagnosis to ongoing surveillance. The aim here is proactive management.
It is. The 3 main goals are determining the current state of fetal health or compromise, guiding intervention, deciding when to deliver, and ultimately, reducing perinatal morbidity and mortality.
We'll start with the cornerstone of surveillance, the non-stress test, or NST.
It's non-invasive, and its purpose is simple: to identify whether the fetal heart rate increases, an acceleration in response to fetal movement.
And the underlying physiology is straightforward but essential.
It is. A FHR acceleration signifies 2 things: adequate oxygenation of the fetus and an intact neural pathway running from the central nervous system to the heart.
So if the fetus is hypoxic, that pathway fails.
It's one of the first systems to fail, resulting in an absence of accelerations.
The procedure is pretty simple.
Very. The woman is in a semi-Fowler's or side-lying position. EFM monitors are applied, and she might use a remote event marker to press a button every time she feels the baby move. The test takes a minimum of 20 minutes, and you, the nurse, are responsible for explaining the process and maintaining that maternal position to ensure adequate perfusion.
And the interpretation criteria are strict. Let's talk about a reactive NST.
A reactive or reassuring NST requires at least 2 fetal heart rate accelerations, where the peak is 15 beats per minute or more above the baseline and the duration is 15 seconds or more, all happening within a single 20-minute monitoring period.
That's the classic 15 by 15 rule.
That's the one. Now, if the fetus is preterm, specifically before 32 weeks, we accept a slightly less stringent 10 by 10 acceleration. So 10 BPM peak for 10 seconds.
And a non-reactive NST.
That just means the criteria are not met within 40 minutes or more.
The big disadvantage of the NST is its high false positive rate. Why is that?
Because the fetus is simply asleep. Fetal sleep cycles typically last 20 to 40 minutes. Failing to see movement or acceleration often just means we need to extend the monitoring time or use a stimulus.
And that leads us directly to vibroacoustic stimulation, or VAS.
Exactly. This is used to interrupt a fetal sleep cycle and confirm that a non-reactive test is benign and not actually due to hypoxemia.
So what is VAS?
It involves applying a sound and vibration device to the maternal abdomen, usually placed over the fetal head, for up to 3 seconds. You can repeat it up to 3 times at 1-minute intervals. The goal is just to wake the baby up and elicit an acceleration.
Does it always work?
Well, fetal brain responses to sound become measurable between 26 and 28 weeks. In a term fetus, this stimulation should result in an immediate and increased FHR acceleration and movement. It's highly effective at confirming reassuring NST findings and can substantially shorten the overall testing time.
Okay, but if the NST stays non-reactive even after VAS, we often proceed to the contraction stress test, or CST.
Right, sometimes called the oxytocin challenge test, or OCT. This is a more strenuous test designed to evaluate the fetal oxygenation reserves.
And the principle here is powerful. You're simulating labor.
In a way, yes. We induce mild uterine contractions. Every contraction momentarily compresses the spiral arteries, which temporarily decreases blood flow and oxygen transfer across the placenta.
So if the fetus is already struggling.
If the fetal oxygenation is barely adequate at rest, this small transient decrease in oxygen supply during a contraction will cause fetal acidosis.
And the sign of that, the sign of uteroplacental insufficiency, UPI, is the appearance of late decelerations.
That's it. The FHR slowing after the contraction has begun and persisting after the contraction has ended. If we see these, it signals fetal compromise because the fetus cannot tolerate even the mild stress of that contraction.
Now, because we're actively inducing contractions, the CST has several serious contraindications. The nurse has to screen for these meticulously.
Absolutely. This includes women at high risk for preterm labor, those with ruptured membranes, a history of extensive uterine surgery, or, and this is the most critical, a history of a classic uterine incision for a previous C-section.
Why is that classic scar so important?
A classic incision, which is a vertical incision into the upper uterine segment, is far weaker than a low transverse scar. Inducing contractions poses a significant risk of uterine rupture along that weakened scar line. It's an absolute contraindication.
Okay, so how do you get the contractions started for the test?
The goal is to achieve 3 contractions of at least 40 seconds duration within a 10-minute period. We can do this in 2 ways. First, breast self-stimulation, which releases natural oxytocin. Or, if that fails, we use a controlled IV low-dose oxytocin infusion.
And the interpretation is precise, a negative CST.
A negative or reassuring CST is the desired outcome. No late or significant variable decelerations. This is a highly reassuring result. It predicts that the uteroplacental unit is robust enough to support life for at least 1 more week.
And a positive CST.
A positive or non-reassuring CST means late decelerations follow 50% or more of the contractions. This is a definitive sign of UPI and fetal compromise, and it often warrants immediate consideration of delivery.
And sometimes the results are in the middle.
Yes, results can be equivocal suspicious, meaning intermittent late or variable decels, or equivocal tachysystolia, meaning decels happening with excessive uterine activity. In those cases, the test is uncertain and has to be repeated within 24 hours.
And the disadvantages are?
It's more time-consuming and costly than an NST, and it requires real precision to avoid inducing uterine tachysystole, which would require immediate nursing intervention, maybe even administering a tocolytic like terbutaline.
Okay, so to synthesize all of these different assessments, we rely on the biophysical profile, or BPP. This gives us the most comprehensive picture of fetal well-being.
It does. It integrates both acute and chronic markers.
So the BPP assesses 5 specific markers. What are they?
One is the NST for FHR reactivity. The other 4 are assessed by real-time ultrasound: fetal breathing movements, FBM, gross fetal movements, GFM, fetal tone, FT, and finally, amniotic fluid volume, AFV.
And the physiological rationale for the BPP is fascinating. It's all about how the fetal central nervous system responds to hypoxia.
It is. The 5 parameters reflect different levels of maturity and resistance to hypoxia. You have the acute markers FHR, tone, movement, breathing, and the one chronic marker, which is the AFV.
Walk me through the sequence of loss under hypoxemia. This seems like a critical piece of insight for a nurse to really understand.
It is. So the physiological centers of the CNS that develop latest in gestation are the most sensitive to oxygen deprivation. Therefore, they're the first to disappear under hypoxemia.
And the earliest developing centers are the toughest.
Exactly. They are the most robust and the last to fail as the fetus attempts to conserve oxygen.
So what's the first marker to go?
FHR reactivity, which is controlled by the most mature, complex CNS components. That is the very first marker to disappear when oxygen levels drop.
And after that?
This is followed sequentially by the loss of fetal breathing movements, then gross fetal movements, and finally, the loss of fetal tone. Finding decreased tone is a sign of severe, prolonged compromise. It means the most basic, earliest developed CNS functions are starting to fail.
And the amniotic fluid volume is the chronic marker? How does that work?
If the fetus is experiencing prolonged chronic hypoxia, it implements blood shunting. It moves oxygenated blood away from non-critical organs like the kidneys and lungs and prioritizes the brain and the heart.
And the kidneys make urine, which is a big part of amniotic fluid.
Exactly. The fetal kidneys and lungs are major contributors to amniotic fluid volume, so this reduced perfusion leads directly to oligohydramnios, or low AFV. That signals long-standing compromise.
The BPP is scored, right?
Yes. Each of the 5 parameters scores 2 points if present and normal, or 0 points if absent or abnormal. Maximum score is 10. A score of 8 to 10 is considered highly reassuring.
And a low score.
A non-reassuring score of 4 or less warrants serious consideration of immediate delivery.
And you mentioned the AFI earlier. That's how we quantify the fluid volume.
Right. The amniotic fluid index, AFI, is the sum of the maximum vertical depth of fluid measured in 4 quadrants of the uterus. An AFI greater than 10 centimeters is generally reassuring. Less than 5 is oligohydramnios and dictates the need for frequent testing or delivery. And an AFI over 24-25 is hydramnios.
Okay, let's wrap up surveillance with the simplest method. Maternal assessment of fetal movement. Kick counts.
This is the low-tech, daily clinical priority that relies entirely on maternal input.
And the nursing instruction here is really important. It's not just about a magic number.
It's not. The key clinical instruction you need to provide is for the mother to establish her baby's personal baseline pattern and to immediately notify the provider when there is a significant change or deviation from that normal pattern, especially if fetal movement suddenly decreases. It's about the change, not a specific count.
What can affect the counts?
Several things. Fetal resting states, variations in maternal perception, time of day, often fewer in the morning, and the mother's use of drugs, including sedatives, illicit substances, alcohol, and tobacco.
But the advantages make it essential.
They do. It's inexpensive, non-invasive, convenient, and it promotes active maternal participation in her own care plan.
Okay. Let's pull this all together and talk about the overarching nursing care for diagnostic testing.
The nurse's role throughout all of these procedures is often underestimated. We are the critical bridge, synthesizing deep clinical assessment with intensive emotional support.
Our assessment priorities start with gathering all the necessary history for the provider.
Right. Gravida, para, exact gestation, any maternal health problems like hypertension or diabetes, current obstetric problems, previous history, substance use, all of it.
But the crucial nursing assessment is non-physical. It's about the patient's knowledge and emotional response.
Yes, we have to know. Do they understand why this test is being done? What does the procedure involve? What's the follow-up? We have to openly discuss the risks and the limitations.
And manage expectations.
Yes. If a screening test is abnormal, you as the nurse need to anticipate the patient's anxiety and remind them that an abnormal screen just dictates the need for a clarification test. It's not a diagnosis yet.
So the inevitable nursing diagnosis in this entire process is often anxiety.
Almost always. Anxiety, directly related to the lack of knowledge and the uncertainty surrounding the fetal condition. Our planning outcome is simple. The family needs to be able to verbalize their knowledge of the testing regimen, feel comfortable seeking information, and feel supported in their uncertainty.
Our interventions center on clear education and therapeutic support.
Right. Providing information means explaining the purpose, frequency, and duration of the tests in simple, clear language. Reinforcing that an abnormal MSAFP result might just be a dating error is crucial information that helps temper immediate panic.
And the providing support component requires high-level therapeutic communication skills.
It does. We have to identify and respond to their feelings of frustration, fear, and uncertainty. Active listening, paraphrasing their concerns to confirm our understanding, reflecting their feelings back to validate them. It's all essential. Even simple comforting measures like supportive touch during a procedure can be invaluable.
And this brings us to the highest ethical priority in the nurse's role: decision support.
Yes. And this is critical. Nurses must never offer personal advice regarding the outcome of diagnostic tests. For instance, whether to continue or terminate a pregnancy based on an abnormality.
Our role is not to advise.
Our role is strictly to help patients contact their support systems, clergy, relatives, social workers, and fundamentally, to provide unwavering, compassionate care and support for the family's final autonomous decision, regardless of our own personal, ethical, or moral beliefs.
We must also help them set realistic expectations.
We do. We explain that the testing helps the perinatal team decide on the best intervention and the optimal timing for delivery to maximize the fetus's chance of survival. But you also have to gently remind the family that even if every single test comes back normal, a baseline risk for abnormalities always remains.
Technology cannot guarantee you the birth of a perfect infant.
It cannot, and that is the essential message we carry, providing hope through knowledge, but also anchoring decisions in reality.
So after this comprehensive deep dive into the technology, the physiology, and the nursing implications, let's wrap up with the key clinical takeaways that you, as the future practitioner, need to carry forward.
Okay. First, ultrasound is your essential foundational tool. It provides structural status, placental status, and the necessary guidance for all invasive procedures.
Second, remember the distinction. AFP and multiple marker screening are highly specific screening tools for open defects and chromosomal anomalies, but they are not diagnostic. A positive result requires invasive follow-up.
Third, concerning invasive tests. CVS provides the earliest genetic diagnosis, 10-13 weeks, but carries that risk of limb defects if done too early. Amniocentesis is used mid-trimester for genetics and critically in the third trimester for lung maturity, where that PGPI testing is essential for diabetic mothers or for RH evaluation.
And PBS is reserved for the absolute highest stakes, blood disorders, infections, and immediate fetal acid-base assessment.
Fourth, antepartum surveillance relies on the NST, where you're looking for FHR accelerations indicating oxygenation, and the CST, which evaluates the FHR response to contractions to detect uteroplacental insufficiency.
And the BPP integrates all 5 acute and chronic markers, with the loss of FHR reactivity being the first sign of hypoxia and oligohydramnios being the sign of chronic compromise.
And finally, your role as the nurse is defined by precise assessment, providing clear, unbiased education and offering unwavering emotional support, ensuring patient autonomy is respected above all else, especially when families are forced to make these profound decisions based on uncertain technological data.
And that leads to our final provocative thought for you to carry into your practice. These tests give us incredible scientific clarity, but they expose profound human vulnerability. Since the technology cannot eliminate uncertainty or guarantee perfection, the true ethical imperative for the maternal-child nurse is not mastering the machine, but mastering the art of supporting the patient's decisions when facing the inevitable unknowns of fetal development. That is the highest level of comprehensive care.